Hi, welcome to another edition of Johnston Health Talk. I'm Liz Thurston with Johnston Health. Today we have a great show for you. We are talking with Dr. John Adams, who is the Medical Director of our Hospitalist program at Johnston Health. Dr. Adams is from Sylva, North Carolina. He attended the University of North Carolina for his undergraduate work and his medical school, and for his residency he attended Brown University. Dr. Adams worked for Rex Hospital for 7.5 years as a hospitalist there and joined Johnston Health in March of this year to join us as the Medical Director of the Hospitalist program. Thank you for joining us today, Dr. Adams.
Thank you.
I messed up the town name there, but
it happens. It's a small town in the middle of nowhere, so most people haven't heard of it.
And we're glad that you stayed in North Carolina to take care of the patients here. And working at Johnston Health, we've been very happy to have you part of that program and being at Johnston Health. A lot of people are not familiar with what a hospitalist is and what a hospitalist program is at the hospital. So I think in addition to talking about sepsis today, which is one of our initiatives at the hospital and I think throughout the country, I would like to talk to you first about the hospitalist program.
Absolutely.
So tell us what a hospitalist does.
So a hospitalist is essentially an internal medicine physician that provides care in the hospital only. Traditionally, they have been internal medicine physicians, but they also include family practitioners. You can have pediatric hospitalists who are pediatricians, and they're actually starting to expand into subspecialties as well. But typically, we work only in the hospital. We work 12-hour shifts, and we provide 24/7 care for the hospital setting. In addition to that, we work on quality measures and patient throughput. That means from the emergency department into the inpatient setting, providing the care during the hospitalization, and then helping with the transition to the next level of care, whether that be home or home with some assistance such as home health, or to a facility such as a skilled nursing facility or a rehab.
So years ago, our primary care doctor would come see us in the hospital if we were an inpatient. They would take care of our care while they were there, as well as seeing them in the office in just an outpatient setting. So what kind of drove the hospitalist programs it's hospitals all over the country, correct?
That is correct. The reason we have moved in that direction is essentially that our patient population has gotten older. As our patient population has gotten older, we are dealing with more complex patients that require more oversight within the hospital setting. You also have to deal with the other issues that have come through medical care. Insurance has changed a lot of what we deal with and how we practice. The primary care physicians are needed in their office to see X number of patients for overhead purposes and their staffing, but also just to supply the care their patients need. And if you look at the Raleigh area, for example, there's Wake Med Cary, Wake Med, Duke Raleigh, and Rex. And if you took a primary care physician and put 3 to 4 of their patients in each of those hospitals, they'd spend their entire day driving around the Beltline instead of actually providing any medical care. In addition to that, by having a presence in the hospital 24 hours a day, for example, when someone has a medical issue that they're clinically deteriorating, instead of the nurse having to try to call the primary care physician at their office or at home, you actually have a medical provider there for you at that moment. And our response times are just much quicker.
Yeah, and you're there, like you said, 24/7. There's hospitalists on site taking care of you. I know that the older population find it very hard to adjust to the hospitalist programs because they want their doctor they've been with for 30 years to come see them. And but you're constantly communicating with their primary care doctor, is that correct?
It is correct. You know, it's one of those things where I tell people we have a very challenging role because we have to form a relationship within about 5 minutes because they have to determine do they trust us or not at that point. And then we have to reassure them that when we admit them, their primary care physician's getting notified. If there are complex questions or issues with management that we have certain questions about, we're going to reach out to their primary care physician during the stay. And then at the end of their stay, we send a discharge summary, which is essentially a recap or an overview of everything that we did for them that their primary care physician needs to know, whether that be studies or tests or lab results or actual procedures, medication changes.
Okay. And you mentioned being involved. Obviously, the quality of care is better like you were saying, you guys are there on site, you're constantly following. When test results and labs, radiology reports come back, you're seeing those immediately. And so managing their care is easier for you than if their primary care came on site.
In a lot of cases it is, because we're familiar with the hospital setting. Most residency programs today, you spend 52 weeks of one day out of the 52 weeks in clinic. Every other day that you're in the hospital, you're actually providing inpatient care. So we're much better prepared to be inpatient providers than we are actually outpatient providers when we finish residency. So we are specialists to provide that inpatient care. We are going to look at all the best practices for inpatient medicine. We're looking at all these quality metrics. We're looking at all the CMS guidelines from the government. And it's just gotten to be very burdensome for the primary care physicians to keep up with all of that.
Right. And so if I was an inpatient staying at the hospital and you were initially my doctor when I was admitted,
yes,
depending on the days that I'm there, I may see a couple people within your team. Is that correct?
That is correct. Actually, you'll typically see at least 2 providers and sometimes up to 3. Mm-hmm. The reason being is if you come in at night, there's going to be the night physician that's there to admit you, and then there will be the provider that takes over your care in the day, the following day. If you're there for multiple days, that provider may switch out to have a new provider come on and complete your hospital stay.
And I know you guys do handoffs for that. You talk about the patients that you're taking care of, and everybody knows full scope what is going on with each patient.
Absolutely. We sit there and we actually do it on multiple levels. We have a verbal sign out, which means you have either an in-person conversation or you call somebody over the phone. The other thing that we do is we have a written sign out.
Okay. And I do want to express to everybody that these are programs that are across the country, and they've been very successful. And as you said, the primary care doctors are just, they need to be in their clinics taking care of the patients on an outpatient basis. And we appreciate all the work that you're doing there. Another thing that you mentioned that the hospitalists do is getting involved with hospital initiatives. And I mentioned that we'd like to talk about sepsis today. And some people may know what sepsis is. I'm sure we know a lot of people have been touched by it somewhere in their life. Let's start out by defining sepsis.
Okay. Sepsis is a life-threatening condition that typically would be described as the infection causing a response, typically inflammatory or otherwise, within the body in which the own body's tissue or organs have damage or die.
Okay. And so there's usually a primary problem, like you mentioned, and then your body's just reacting to that sickness or wound, whatever it is that you may have, and so we call it sepsis. And the word, I always think of toxic.
Yeah, it is a toxic release of inflammatory markers to the body that then cause a overwhelming response.
And so the drive now really, and I guess across the country, is really to create awareness of sepsis. And September is Sepsis Awareness Month, yes, which is why it's a good time to do this program. But I was reading some statistics that only about 50% of the population know what sepsis is.
That's correct. It's a diagnosis that hasn't been really championed until recently, but it's become a very important measure within the hospital setting. And it's because there are so many common things that can cause it. The typical signs of sepsis would be that you have an infection with either a fever, very high temperature or very low temperatures. It can be associated with high respiratory rates and confusion. Things that come across are, as far as sources, would be pneumonia, skin infections such as cellulitis or abscesses, urinary tract infections, and as well as less common infections, including the brain with meningitis and encephalitis and things of that nature.
And it's scary because I'm the type of person that when I'm sick, I don't go to the doctor or to the hospital unless it's absolutely necessary. And I think a lot of people are that way. And you may think you have the flu. But on the other hand, if you had a source problem going on and these other symptoms arise, you really need to get to the hospital as soon as possible.
You really do. You either need to talk to your primary care physician who can help direct you either to come to their office or be directly seen in the emergency department. But it is very important to be evaluated. These aren't things that it's imperative not to delay care. By delaying the initiation of care by up to an hour, you increase mortality by, I think, around 7 to 8%.
Oh, wow.
So it's a very important measure where if you are having fevers or you're experiencing shortness of breath and you just don't know what the cause is and it's worse than normal, you should be evaluated by a provider.
And when you come into the hospital at Johnston Health, and I'm sure I know it's a UNC initiative across our systems, that's something that's being identified as soon as you walk in the door. We're trying to make sure that we recognize those signs and treat it immediately, even if it hasn't been truly diagnosed yet.
Absolutely. You're starting to evaluate those patients as soon as they reach triage. They're going to have an evaluation by a nurse there, taking their vital signs. If somebody meets certain criteria, they're going to be expedited back into a patient room. They're going to have labs and studies ordered, and then they're going to have the initiation of treatment. And the treatment can include anything from aggressive IV fluid resuscitation to IV antibiotics, as well as in certain cases where we go into the realm of septic shock, where the person's blood pressure remains low despite aggressive fluids, that we may have to give a medication called a vasopressor. And vasopressors are medications that essentially cause the body's blood vessels that have been dilated to shrink. And it's just like a pipe at your house. If you take a big pipe with a certain amount of fluid in it, it's going to have a lower pressure than if you make it a smaller pipe with the same amount of fluid.
Okay. It's amazing, really, when I learn more and more about this issue and the awareness that we're doing at Johnston Health and across the system to create awareness not only with patients and the community, but also with our staff.
Yes.
We've been doing quite a bit. I know you're part of that team, sepsis team, and very involved with the initiative to educate. Some of the things that we're doing at the hospital, I've seen some storyboards, information boards, and of course our little ribbon here that kind of creates awareness as well. What are some other things that you guys are doing?
We're focusing right now on education for staff. We need to recognize these patients as soon as possible to make sure that they get adequate treatment. And it's not just in the emergency department, it's after they've been admitted. We have to follow them. This is a 6-hour window, which is one of the reasons it's so challenging to take care of patients in each 6-hour window, because the 6 hours resets every hour. And in that setting, we're also putting up information in our sign-outs that are stressing whether or not somebody needs something from a septic standpoint. Additionally, we're looking at telling the stories of our sepsis or our septic patients. It's a story of a marble, and the marble signifies each weekend that a person has. And if we save a septic patient, we're going to add a marble to a collection, probably that's going to be set up somewhere in the hospital where we can start seeing the results and how it's been beneficial not only to the patients, but it also shows staff where we're making strides and that we are being successful, and that patient gets more Saturdays with their families and their loved ones because of the care we provided.
Now, if someone is diagnosed with sepsis and it's caught early enough and treated, is there concern in the future if you have a source wound or sickness that you could become septic again? Does it make you more liable to get it, I guess?
That's a tough one.
Okay.
You know, the hard part is that these patients are very, very sick. And when they're very, very sick, they're going to have the potential to come back to the hospital. Within 30 days, actually a significant number of people are rehospitalized. And in addition to that, you have to look at that certain conditions, patients with cancer who may be on chemotherapy and have immunosuppression, patients with diabetes, patients with end-stage renal disease, patients with burns, they're going to have higher risk to become septic. It's not truly that they were septic and that makes them at a higher risk. It's their other medical conditions that raise their risk overall.
Yeah, and I think it's important to point out too that sepsis is not, does not discriminate against age, race, anything. I mean, any person can get sepsis. We've heard so many stories from 2 years old, 40 years old, and up. And it just, as you said, it's just depending on how sick they are and, if they can track that.
Absolutely. It's very indiscriminate. It does not matter if you're 4 years old or 34 years old or 90 years old. Everybody can be exposed, and everybody can have the condition and the effects of the infections.
And some of the statistics that I had been reading, and also if anybody wants more information about sepsis, the website sepsis.org has some great information, which is where I collected a lot of my information in addition to our team at the hospital. But you had mentioned that every hour delayed sepsis increased mortality by 7.6%.
Oh, wow.
And that just really stresses why you need to get to the doctors, need to get to the hospital if you're having any symptoms, and it be treated right away, because that would make the difference, the treatment time.
Absolutely. Even the severity of sepsis that we're dealing with affects survival rates. And so there's initial sepsis, which is lower in severity. It has a 30% mortality rate. Severe sepsis is approximately a 50% mortality rate, and septic shock can be as high as 80%.
Wow. And another statistic that I have here is sepsis kills 258,000 Americans each year, and 1.6 million Americans develop sepsis during hospitalization each year, and nearly 250,000 die from sepsis related to complications.
That is true.
And that's why it's so important that we spread this word to the community and educate our staff. And I know that the team is very excited, and a lot of them have personal experience with this.
Sepsis, it can change lives. And my story is more of a story really about second chances. And second chances given to me by a health team that was prepared and acted quickly during a crisis septic situation for my own son. My son Chase in 2010 was diagnosed with ALL, acute lymphocytic leukemia. He was 3, and that's a life-changing event just in itself, but little did his mother and I know that what would follow would be even more impactful. On day 4, Chase received a chemotherapy drug called L or pegosparaginase, and on day 17 he had an unexpected reaction to that drug. He developed pancreatitis, and it was full-blown pancreatitis, to the point of rips and tears and pancreatic fluids going out throughout his body cavity. He had all those signs of, like the Cullen sign of a blue ring around his belly, where those fluids were literally eating his insides. Pseudocysts, he had drains coming out of his stomach. And anytime you start dealing with the GI tract and those microorganisms that we have in there, and then introducing them to the body, and then having an immunosuppressed state to begin with, it's just not a good combination. But so what does septicemia mean to me and this team, the work that you're going to do? It means second chances for somebody else. The work that you're going to do today actually is going to save somebody's life tomorrow, and it really will, and I've lived it. I'm proud and excited to be part of a team that we really take that to heart. We take time and energy and resources away to do things like what we're doing here today. So just know that the decisions that you're making today, the advancements that have come in the last 6 years, you can take that information and piece it together and give someone else a second chance, just like I had a second chance, with my own son and our family with Chase.
And it's been a great initiative across the system. Have you seen a lot of success from putting these different protocols in place?
We've seen a great number of, a great amount of progress.
Mm-hmm.
This is a system-wide initiative. It's not just a Johnston Health issue. This is a UNC healthcare issue. And you have, from the top down at UNC Healthcare, meaning the UNC hospital systems, Rex Hospital, Johnston, Caldwell, Pardee, the entire system is working together to provide the best care that we can for patients. And we're starting to see better and better success because we're utilizing the resources throughout the healthcare system to support each other and prop each other up in the ways where we may not have been as successful as individual hospital units.
Okay. And this initiative started about a year and a half ago, I think. I was on the initial team for that, which was such a great experience to see people working together to make this happen and take care of our patients. Have you been on that team since you've joined us?
Sepsis has been an imperative part of our care plan since I started, and yes, I've been very involved in the whole sepsis program at Johnston Health, as well as reaching out to the healthcare system. It's been a significant challenge because some of the guidelines and expectations of care continue to change, and so we're trying to meet those as those changes come out. We're trying to adapt as best we can because we want to provide the best clinical practice to our patients at all times.
Now, are these, as far as measuring success and putting these protocols in place, is that something that was developed from the system, or is there an organization that's kind of helping to push this awareness?
So it's actually from the government.
Okay.
It's called Cms Guidelines, and they're essentially putting out their recommendations for care. Within the UNC healthcare system, they had tweaked or adjusted some of those guidelines to try to improve our capability of meeting those metrics and trying to be a little bit more aggressive so that we're ahead of the curve instead of trying to be reactionary.
Yeah, and some of the statistics that I have seen that the hospital's been gathering as we've been initiating this and educating have been very positive. And so it's great to see that happening across the system as well. And I think we're actually doing a little better than some of the other hospitals in the system.
I don't know the latest statistics, but I know we've made significant strides in the 5 months that we've really focused on it and have made great strides in communication, because at the end of the day, the most important aspect of this is communication between providers, whether it be the emergency room provider to the admitting hospitalist or the admitting surgeon, or from the nurse in the emergency department to the nurse on the floor, as to what steps have actually been completed and that everybody's aware of what needs to happen next.
Right. And we appreciate all the efforts that you guys have put into this initiative, and I'm sure our patients appreciate it as well. And I just hope that the community is really listening to all this information that's being released about sepsis, and there'll be more to come. We'll have more educational sessions and really doing our part to educate. You mentioned CMS, and really all hospitals are governed by CMS, and they have many initiatives that we work on, sepsis only being one of many.
Yes.
What are some of the other things that you guys are working on?
You have to worry about Dvt Prophylaxis. That's a clot that forms in somebody's leg when they're immobile due to inactivity, and that typically happens in a hospital setting just because somebody's so sick they're not getting out of bed and doing the typical walking that they would do. You have to worry about core measures with stroke care. You're looking at acute myocardial infarctions or heart attacks, and you're looking at your infections are related to catheters that are placed in patients' bladders when they're admitted, or central line infections, which are essentially larger catheters that are placed either in someone's neck, under their subclavian, or in their groin.
And those measures we look at on a daily basis, and I know they're reported out on a monthly basis to all the leadership and staff. And I just want to show everybody that these initiatives are happening across the country. CMS has these guidelines, and it's all about improving patient care and saving our patients, and just doing everything we can to provide quality care.
Absolutely, and the steps that are in place are ever changing. We look at it daily, it's reported monthly, but in cases where we see that we may not be meeting the metrics that we need to, we're addressing that before that monthly report comes out. It's something that we do at all times, that we want to be providing that care to our patients as best as possible.
Yeah, and I know we work very closely with the quality department, and they look at that, like you said, on a daily basis. And anything that may be dropping off for whatever reason it may be, it's being addressed immediately. And again, that's happening across the country. Patient care is number one for everybody, and We appreciate you coming on the show today and talking to us and explaining to everyone what the Hospitalist program is and these initiatives for sepsis, which is just so important. Please get some more information on the internet at sepsis.org. You can also speak with your primary care doctor. Anybody in healthcare can give you some more information. This is an important topic that I think everyone needs to be educated on. And get to the doctors if you're sick. Don't wait. It's so important that you take care of your health. And thank you, Dr. Adams, again for coming on the show today. We really do appreciate it.
No problem. I would like to add one other thing. We're about to enter the flu season.
Oh, yes.
Please pursue your flu vaccination. We've already had multiple cases in Johnston County that have been hospitalized as well as taken care of in the outpatient setting by their primary care physicians. So please pursue your vaccination. It's very important.
And I'm glad that you said that because just recently I had my child just for a wellness checkup and was told the same thing, that the flu's already out there. It's kind of early this year. Get your flu shot. It will last you throughout the season. If you get it too early, doesn't mean that it's not going to last till spring. That it's very important that everybody be vaccinated because if your immune system is low, then the flu could be very dangerous.
Absolutely. You can actually even become septic from the flu.
Oh, I didn't realize that.
Yes.
Okay, well thank you so much, and thank you for joining us for another edition of Johnston Health Talk, and I hope you will join us again soon. Thank you.